So good morning. In the last class we have discussed about few classes of these immunosuppressant drugs. So now we are going to discuss the next class, that is glucocorticoids. So these glucocorticoids have the immunosuppressant action as well as anti-inflammatory actions. How they suppress immunity is they will inhibit the, if you see this MHC class expression. So if MHC expression is coupled then only there will be the activation and proliferation of T cells. So these glucocorticoids will inhibit, okay. So these glucocorticoids will inhibit this MHC expression. So if MHC expression is inhibited, so there will be no coupling process and no proliferation of or activation of T lymphocytes, and if T cells are not proliferated and activated, there will be no immune responses occurs. So next, these glucocorticoids are most effective in the conditions of graft rejections, as well as these are employed or these can be given in the route of IV, that is intravenous, in the larger doses. But even the glucocorticoids are given in the larger doses, but they are employed only for the short period. Again I am saying, so these glucocorticoids have both anti-inflammatory action as well as immunosuppressant action. So coming to the immunosuppressant action, how they act is they will inhibit the MHC expression, that is major histocompatibility class expression. So if this class expression is inhibited, because if this class is not coupled, so what happens, there will be no activation and proliferation of T cells, and if the T lymphocytes or T cells is not activated, there won't be further production of any immune responses. So these are used in the treatment of graft rejection, as well as these are employed in the route of IV, that is intravenous, for within the larger doses, means by larger doses, and that term or course will be employed for the short periods. And next one, so next class is biological agents. So before discussing about the biological agents, first class is TNF inhibitors. So what is this TNF? See, if you observe these TNF inhibitors, no? So first coming about the introduction of TNFs, this is nothing but the tumor necrosis factor. So this tumor necrosis factor will amplify the immune responses, okay, by releasing various kinds of enzymes like collagenases and metalloproteinases. So normally this TNF is going to amplify the immune responses. So if immune responses are amplified, so most of the immune system will produce responses during the graft transplantation. So we have to inhibit that. So we have to inhibit this tumor necrosis factor also. So then coming to the types of these TNF receptors, there are like two types, TNF alpha and beta, and they are expressed on the surface of neutrophils, endothelial cells and fibroblasts. So next, this TNF alpha inhibitor class of drugs will inhibit this tumor necrosis factor, and if this tumor necrosis factor is inhibited, it won't amplify any immune responses and there will be no production of immune responses. How this TNF causes the immune responses? By releasing various kinds of cytokines and various kinds of enzymes like metalloproteinases and collagenases. So these, the class of drugs which belongs to TNF alpha inhibitors will inhibit the TNF alpha receptors. And next one is, the first drug in this TNF alpha receptor is etanercept. So this is nothing but a protein which is fused with the TNF receptor with the antibody, that is IgG1 antibody of the humans. So this etanercept will neutralize both TNF alpha and TNF beta, if you observe. So the first class of drug which is included in this TNF alpha inhibitors is, so etanercept, and this is the fusion protein which is fused with human TNF receptor along with the antibody IgG1, and it neutralizes both TNF alpha and TNF beta receptors. So the mechanism of action is it prevents the activation of macrophages and T cells, and if those are inhibited, means if those macrophages and T cells action is prevented, then there will be no production of immune responses. So that is the MOA of etanercept. And next, coming to the uses of this, so it is used in the conditions of rheumatoid arthritis along with methotrexate, and It is also used in conditions of spondylitis as well as arthritis and plaque. That is, in psoriasis conditions also it can be used. So once again I am saying this etanercept, it is the protein which is fused with the receptor like TNF receptor along with the antibody, that is IgG1 antibody. So it neutralizes both TNF alpha and TNF beta. So coming to the MOA, it will inhibit the activation of macrophages and T cells. So if the activation of macrophages and T cells are inhibited, so they won't produce any immune responses. So that is the MOA of this drug. So coming to the uses, it can be used in the conditions of arthritis along with methotrexate also, and it can also be used with spondylitis, and it is also used in the conditions of psoriasis. So next type of drug in this TNF inhibitors is infliximab. If the drug ends with the AB, that means it belongs to the class of antibodies, like it is the monoclonal antibody, and it shows its action against TNF alpha receptors, and it activates these TNF alpha receptors. So this drug will bind to the TNF alpha receptors and inhibit the actions of this TNF alpha. So it is given in the form of IV infusion for every 4 to 8 weeks. So same like before drug like etanercept, it is also given along with methotrexate and other conventional therapy. So it is also used in the conditions of rheumatoid arthritis, Crohn's disease, colitis, psoriasis and spondylitis. The uses are similar. And next one is coming to the next drug, adalimumab. So it is also ends with the AB. That means it is also a antibody, and it also shows its action against the TNF alpha. So if TNF alpha is inhibited, so there will be no amplification of that immune responses, and like that this drug can prevent that immune responses, and it also binds to TNF alpha receptors and inactivate that receptors. And coming to the TNF beta, it won't bind to the TNF beta receptors, and it is less antigenic, and it also can be used along with methotrexate. So whatever the TNF alpha inhibitor class of drugs are there, so these drugs can be given along with methotrexate in order to treat the arthritis condition. Not only arthritis conditions, these drugs can also treat the other autoimmune disorders like psoriasis, Crohn's disease, colitis, ulcerative colitis, etc. And next class in the biological agents is interleukin 1 receptor antagonist. In the name itself is there. So these drugs which belongs to this class will inhibit these IL-1 receptors. So interleukins are also involved in the immune responses, right? So these class of drugs will inhibit that interleukin 1. So first one is anakinra. So it also binds to the IL-1 receptor and acts as an antagonist to that IL-1 receptors, and it prevents the activation of interleukin 1 binding to its receptor, and it is also used in the conditions of rheumatoid arthritis. So if the arthritis is not responded to the disease modifying anti-rheumatoid drugs, so then this drug can be employed, and it can also it is used as a TNF alpha antagonist. So coming to the next class, that is IL-1 receptor antagonist. So in the name itself is there. So these class of drugs will bind to the IL-1 receptor and inhibit the actions of IL-1 receptor. So the first drug is anakinra. So this is used in the conditions of rheumatoid arthritis. So if those patients who are not responding to the DMARDs, that means this is modifying anti-rheumatoid drugs. So if the patients are not responding to the anti-rheumatoid drugs, so then they can be switched to, means they can use this type of drug like anakinra, because this drug will bind to the IL-1 receptor and inhibit the activities of IL-1 receptor. If these IL-1 activities are inhibited, there will be no production of immune responses. So next one is IL-2 receptor antagonist. So normally CD25 molecule is generally expressed in the activated T cells but not in the resting T cells. That means, so there is one molecule like CD25. So this molecule is expressed on the immunologically activated T cells but not on the resting T cells. So this drug which is there, the first drug, like if you see daclizumab. So this drug in place of CD25 will bind with this IL-2 receptor and inhibit that IL-2 actions. Generally, CD25 molecule is expressed on the immunologically activated T cells and it has the high affinity towards that receptors. So the drugs which belongs to this IL-2 receptor antagonist, in place of CD25, they will bind to that receptor and inhibit the actions. So if you see, so this daclizumab is a monoclonal anti-CD25 antibody. So it binds to that CD25. So in place of CD25, it can grasp the affinity and next it will inhibit this IL-2 receptor activities. And it can be given along with the glucocorticoids and calcineurin inhibitors like cyclosporine, as well as it can also be given in the combination of azathioprine or mycophenolate mofetyl. So coming to the uses, so this drug is used in the renal transplantation as well as other transplant rejection reactions, that is in graft rejection reactions also this drug can be employed. And coming to the plasma T-half of this drug, it is long, like 3 weeks. So daclizumab, so it belongs to the IL-2 receptor antagonist. So actually CD25 molecules are expressed on the surface of T cells. So in place of that, so these drugs are the antagonists to that CD25 molecule. So they will bind to that CD25 molecule and acts as an agonist and inhibit the activities of IL-2 receptors. So if the activity is inhibited, so there will be no production of immune responses. So next drug in this IL-2 receptor antagonist is basiliximab. So it is also similar to that daclizumab only. So MAB, that means it also belongs to the antibody class, that is it is anti-CD25 antibody and it has a higher affinity for this IL-2 receptors, but comparing to the before drug, that is daclizumab, it has the higher plasma T-half, but this drug has the shorter T-half, like 1 week. And the clinical uses are similar to the previous drug like daclizumab. And coming to the dose, it can be given in 20 mg through the IV route and it is sold under the name of Simulect, that is 20 mg per vial injections. So both daclizumab and basiliximab can produce anaphylactic reactions, as well as it can also causes peripheral edema, fever, headache and dyspnea are the side effects. So coming to the side effects of these IL-2 receptor antagonists, so they can cause this edema conditions, fever and headache, as well as this dyspnea, that means difficulty in the breathing. So next drug is muromonab CD3. So it is also a monoclonal antibody and it shows its actions against this CD3 glycoprotein. So this CD3 glycoprotein is expressed near the surfaces of T cell receptors. So this muromonab CD3, it is the antibody which is produced against this CD3 molecule. Generally this CD3, same like CD25, acts on the surfaces on the T cells. So they will bind to that muromonab CD3 will bind to that CD3 antigen and it will inhibit the approach of this antigen to this complex, means to form the complex. So again and same, this muromonab CD3 will bind with the CD3 molecules and inhibit the approach of the formation of complex. So if this MHC class 2 and if CD3 complex is inhibited, so there will be no activation of T cells, means there will be no proliferation and activation of T cells, like that immune responses can be inhibited. So first this muromonab CD3 has side effects like cytokine release syndrome, like flu-like symptoms it can produce, like chills, rigor, malaise and high fever as well as wheezing. So this can be due to the release of the various mediators like TNF alpha, interleukins and interferon, and these symptoms decrease when we decrease means this symptom will decreases in severity with subsequent doses, means based on the doses the symptoms can increase, or if you decrease the dose the symptoms somewhat can be relieved. So this muromonab CD3, so it is a monoclonal antibody and it shows its action against the CD3 glycoprotein. Generally this CD3 will form complex with the major histocompatibility class 2, and then it leads the activation of or proliferation of T cells. So if this is inhibited, so the T cell activation and proliferation is also inhibited, and if this is inhibited, immune response are not produced. That is about the muromonab CD3, but it has a side effects like it can produce cytokine release syndrome, like flu-like symptoms, like which results in chills, rigor, high fever, malaise. So next one is polyclonal antibodies. The first drug is anti-thymocyte globulin. So it is also polyclonal antibody which is purified from the horse or rabbit. So it is purified, this globulin or this antibody is purified by immunizing the animals like horse or rabbit with the human thymic lymphocytes. So whenever we introduce these human thymic lymphocytes in the horse or rabbit, so they produce the antibodies, no? So that like that this obtained antibody is this anti-thymocyte globulin. So it is the polyclonal antibody which is purified from the animals of horse and rabbit, and they are immunized with a lymphocyte that is known as human thymic lymphocyte. So this drug, like this antibody, will bind with the T lymphocytes and can deplete the T lymphocytes. So it can also show its action on the cell mediated, like that it can show its action on the cell mediated immunity. So this is the immunosuppressant drug, and it is also used in graft rejection problems, and it can also given with combination with these steroids. Coming to the brand name, like it can be sold under the name of lymphoglobulin, that is 100 mg per vial injection. If it is if the antibody is obtained from the horse, so it is sold under the name of lymphoglobulin, and if it is obtained, means if the antibody is obtained from the rabbit, so then the name is given like thymoglobulin, and the doses are given on the screen. So polyclonal antibodies, so these antibodies in these polyclonal antibodies, the first drug is like anti-thymocyte globulin. So it is nothing but the antibody, so it binds with the T lymphocytes and deplete the T lymphocytes. So if T lymphocytes are depleted, there will be no initiation of the immune responses. So this antibody can be administered within 72 hours of the after the delivery or abortion in order to prevent some hemolytic diseases, and it can also given to prevent the hemolytic jaundice in the week of 28th week of the pregnancy. It has to be administered in order to prevent the hemolytic jaundice. So coming to the dose, it is given in the dose of 250 to 350 microgram through the intramuscular route, and that will be like a freeze-dried preparation, and it is sold under the name of Ricimen, Rogam and Imogam, that is 300 mg per vial. So what is the MOA of this polyclonal antibody? That is anti-thymocyte globulin. So that antibody will bind with the T lymphocytes and depletes the T lymphocytes, and if these lymphocytes are depleted, there will be no initiation of immune responses. So next, the uses. So the immunosuppression in organ transplantation. So these all the immunosuppressants can be administered in 3 ways, like induction regimen, maintenance regimen, as well as anti-rejection regimen. So first, induction regimen, that is starting. So this is given in the pre-operative period. So we have to give these immunosuppressants before the transplantation, that is, so they have to be started, means this course has to be started before the transplantation, about 2 to 12 weeks before the transplantation, and this course has to be given even after transplantation up to 2 to 12 weeks. So induction regimen is nothing but this course has to be started before the transplantation and continued up to 2 to 12 weeks after the transplantation also. And coming to the common regimen, it can be given with the triple therapy like cyclosporin or tacrolimus or sirolimus with the prednisolone and mycophenolate mofetil or azothioprine. So first, induction regimen is nothing but how this course will be started, means this regimen includes a triple therapy with drugs like with a drug combination like cyclosporin, tacrolimus or sirolimus along with prednisolone, and another one is azothioprine or mycophenolate mofetil. So it has to be started before the transplantation and can be continued after the transplantation also, that is from 2 to 12 weeks after the transplantation we can continue this regimen. So next one is maintenance regimen. Maintenance, that means we can take this regimen or dosage for the prolonged periods. So the drugs involved in this regimen are same like before, that will be a combination of triple regimen like cyclosporin or tacrolimus, sirolimus along with prednisolone and azothioprine or mycophenolate phenolate. So next one is anti-rejection regimen. So anti-rejection regimen is given in treatment of graft rejection problems, and this regimen is given in order to suppress the acute rejection problems. So in this we will use the combination of steroid, that is methylprednisolone in the dose of 0.5 to 1 gram through the IV daily. So this combination like steroidal therapy is employed in the conditions of acute rejection problems. And last one, like adverse effects of these immunosuppressants. So the adverse effects includes, so it can result, means all the immunosuppressants can result in various infections, like they can predispose various types of infections like bacterial infections, fungal infections and viral infections. So in viral infections, majority of the patients are prone to this CMV infection, that is cytomegalovirus infections. And next one is there may be also chances of development of malignancies like lymphomas, and related malignancies can be developed by using these immunosuppressants. So this is all about the immunosuppressants.